we'll start the topic. Okay. So we'll go through some of the scenarios. But scenario one, the 3-year-old child brought in the night to the ER in febrile status was treated with multiple anticonvulsants, seizure controlled, and intubated because of poor GCS and inability to maintain the airway. And child was taken to the PICU. Next day morning, no further seizures. Child is alert, GCS 13, and has spontaneous respiratory drive. So this is the one scenario. See, for second scenario, it's a 3-year-old child admitted with severe pneumonia and sepsis, progressed to ARDS, respiratory failure, and child was intubated and ventilated for 1 week, and now showing signs of improvement. Another scenario is a 4-year-old child was admitted with status asthmaticus 2 days back. So admitted to the PICU, worsened, and needed intubation. And with ventilator support and intensive medical management and needed ketamine also, now the child is becoming better. So you actually, all these scenarios, you have to wean the child from mechanical ventilation to spontaneous, mainly his spontaneous respiration. So we are going to deal with how you are going to wean from mechanical ventilation. So I think I am not going to this Zoom platform is actually good because you will get more time for the practical classes in the workshop, and that is what it is really meant for. But I am not so much comfortable with this Zoom platform. So we'll go for how will you win. So when you see these three scenario, do you find is there any difficulty in difference between the three scenario? The first scenario is the airway and the lung parenchyma is absolutely normal, and there was problem with the because of the poor GCS, child needed to be intubated, and the child is now perfectly okay, and the child can be extubated. There is no much confusion in that. The second, the child has severe alveolar pathology, and he has developed ARDS, and now you don't know whether the child can be. You don't know the ideal time for starting weaning. So that is a second scenario. And the third scenario is actually a child with an obstructive airway disease, that is the asthma. Actually, I will come to all these things. So actually, these are the three different scenarios where the mode of ventilation and the settings of the ventilations are basically differing. So what is weaning? Weaning is a process of decreasing the ventilatory support, and at a time when he is able to take care of gas exchange mainly with his own spontaneous respiration. So from the ventilatory support, he has to go for predominantly his spontaneous respiration, but you have to find what is the optimum time for that. So, so the extubation is actually the last step. So from mechanical ventilation, we have to extubate the child. So before that, the child has to be tested whether he is ready for a weaning trial, and then if he is tolerating the weaning trial, he can be extubated. So the extubation is the last step for weaning from mechanical ventilation. So we'll come to the scenario one. So I told already about, we'll come to this scenario in the last part, the examination. So the weaning has three phases. So readiness testing. So you have to whether the child is fit for a weaning trial. So that is readiness testing. And then you do the weaning trial. And during the weaning trial, you have to monitor the child because the child can sometimes go in for a weaning failure. So sometimes child will pass the test and then you can extubate the child. But sometimes the child can go in for a weaning failure. So the child has to be intensively monitored. So the readiness testing is you have to identify patients who are ready to wean or not ready to wean. And you have to find at the right time because it should not be early or it should not be late. So if you wean him early, so there will be a cardiovascular dysfunction, there will be a respiratory muscle fatigue and psychological stress. If you prolong the ventilation, there will be a trauma to the lung, pneumonia, a ventilator-associated pneumonia, and long hospital stay and subsequent problems. So he has to be weaned at the right time. So whether he is fit, so So this is to be done for all children if it is more than 24-hour on ventilator. When going to the first scenario, the child was, so the next day child was okay. The child was, the seizures were controlled. It was a febrile status. There was no other problems. And the child was fit for weaning immediately, weaning and maybe extubated. And the second child, you see that the child is having prolonged the ARDS. The disease, the nature of the disease itself is it will take a longer time for it to resolve. So and of course, so you don't know whether when the child you can start weaning, of course. So we'll come to that. And the scenario 3, I have to say something about this scenario 3 because it's a child with a status asthmaticus. So status asthmaticus usually as a last resort only you will be ventilating a child because the child usually you should try all the medical management and NIV also and all the intensive medical management, the nebulization and the NIV, and then only you have to go for the ventilation. So ventilation is resorted only when there is a hypoxia or a severe hypoxia with hypercapnia, or when the child is the sensorium is there is alterations, child's sensorium, child is drowsy, child is respiratory muscle fatigue, respiratory rate is coming down in spite of the SpO2 is also coming down. So because the tube inside the airway, which is already in a dynamic airway obstruction, is going to cause a lot of problems. So only to tide over the crisis, only you are putting the child on ventilator, and the weaning, once the child becomes improved, immediately you have to wean the child. So the weaning mainly depends on the indications for starting the mechanical ventilation and the disease and the improvement. So we'll go by one. One is the readiness testing. So the readiness testing I have already told, and it should be done daily. So daily screening liberation assessment. That means you have to do daily when the child is improved, and then you know the child is maybe going. You can wean off him from ventilator. So you have to do an assessment daily, and whether it is a protocol based or physician based is always a question. And usually there are evidences only in adult literature, and so the protocol based, there are some studies which are favoring protocol based, there are some studies which are favoring physician based. The liberation protocols, they are objective, and they are saying that the clinicians usually underestimate the patient's capacity to breathe spontaneously. That means if you are using a protocol, you can wean him earlier. That is some of the studies says. But when you go to some other studies, when the physicians, there is an experienced physicians, and there is very good staff pattern in the PICU. So the weaning time is less. You can wean him early when compared to a protocol-based weaning. So usually whatever is that, so protocol-based, you can it can be made by the nurse or the respiratory therapist as it is done in the West. But what we are not doing that things. But in children, in pediatric, usually it's a physician based. But the physician can take his experience as well as a protocol based when he takes into the decisions. So the mode of weaning may change depending on the indications for ventilation. So I have already told. So weaning mainly depends on the indication for ventilation, the nature of the disease, and improvement of the disease. So disease, we are going for a readiness testing. With after ventilation, after the management, we feel that the child is ready for weaning. So then there are some prerequisites to be satisfied. So you have to go through all these prerequisites, and all has to be satisfied before he is put on a weaning trial. So what are those prerequisites? So there is a clinical criteria, that is the improvement in the indication for initiating the mechanical ventilation. Why you have started the mechanical ventilation? If it is a poor GCS, the GCS has to come back to normal. If it is severe hypoxic respiratory failure and respiratory muscle fatigue, all the ARDS, all these things, it has to improve. So the improvement in the indication for initiating the mechanical ventilation. And it is an airway obstruction, it has to resolve. So whatever is there, it has to resolve. Then second is adequate oxygenation and ventilation, hemodynamic stability, arterial pH more than 7.25, and ability to take spontaneous respiration and airway protective reflexes. So these all has to be satisfied. If any of these are not satisfied, you cannot put the child for a weaning trial. So simultaneously, the improvement in underlying conditions, that is the ARDS, the asthma, or whatever it is, it has to improve. That you have to assess by the clinical lab and radiological. So whatever investigation, the basic disease which has caused the problem has to resolve. Then we'll go by one by one. One is adequate oxygenation. So that is PF ratio, PaO2 by FiO2 more than or equal to 150, or when the SpO2 is more than 90 to 95%, when he is receiving an FiO2 of 0.4% and 0.4 and a PEEP of 5 centimeter or less. So PEEP 5-ന് താഴെയോ 5-ന് താഴെയോ FiO2 0.4 അതിന് താഴെയോ ഉള്ളപ്പോൾ PF ratio is more than 150 or SpO2 is more than 90 to 95. That is one thing. Then the higher level of PEEP may be acceptable in patients with abdominal distension. This 5 centimeter can be sometimes obesity, abdominal distension. You can give it can be 6 or 7. You can there can be some variations in certain depending on certain conditions. And then the FiO2 of 0.5 when significant underlying lung disease is present, severe pneumonia, ARDS, sepsis related or otherwise related ARDS. Then if the underlying lung is having a severe underlying lung disease, the FiO2 instead of 0.4, we can keep it as 0.5. And the PCO2 should always be less than 50. So this is what adequate oxygenation and adequate ventilation. The oxygenation and ventilation is adequate. And the second is arterial pH. That should be more than 7.5 usual. Usually any child, such child, a normal child getting some problem, that child, when you assess that child, there should not be any acidosis. The pH should be more than 7.5 in all acute conditions. In the child, suppose the child is having a previously problem or a neuromuscular problem or a renal tubular acid or a chronic renal failure, chronic metabolic or respiratory acidosis, then the child's previously also the child's pH may not be may be little lower. So then you can give allowances. You can estimate a targeted value and you can take your decision. And the potassium, calcium, magnesium, phosphorus, all these and the electrolyte values always should be checked for. And the hemodynamic stability. So the mean arterial blood pressure for different age, it has to be there. The basic the cutoff for the mean arterial blood pressure for different age should be there, and the child should be on no inotropes or minimum inotropes. And the ability to initiate respiration. The child has the ability to initiate respiration. How will you know that? Usually should be above the ventilator rate. So if you fix a ventilator rate, suppose a child is breathing above the ventilator rate, the child is having a spontaneous, so he is initiating respiration and spontaneous respiration. Or you can set the rate below for some time and then see the child will be initiating his own respiration. So all these prerequisites has to be satisfied before you put the child for a weaning trial. And these are not critically needed, absolutely needed, but is desirable. So that is a hemoglobin level of more than or equal to 7, no fluid overload, and the child should not be febrile. It should be less than 38.5, and awake or arousable mental status, which Richmond agitation scale. So this is desirable, but not always absolutely needed. So suppose you are in uncertainty when you put this clinical criteria. So you are uncertain, or a child who is on prolonged ventilation, or child you think a critical or a neuropathy or some other problem or ARD or something is there. Sometimes then you can go for some tests like some indices, RSBI, rapid shallow breathing index or prop index. But the evidence-wise, so there is no it is usually routinely not used, and the evidence-wise also it is not much helpful. It's a physician-based. This is more going to be useful as far as the evidences are concerned. So then you go for the breathing trial. So if the child is having the prerequisites for weaning trial, then you can go for the weaning trial. So the breathing trials can be spontaneous breathing trials can be unsupported, so totally unsupported. That means the child is not supported. Not of the any breaths are no, is not supported. So he is connected the ET tube is connected to the TPs. So you are giving an oxygen the delivery. So that's all. So nowadays nobody is doing this TPS test except where you definitely are sure that the child is going to extubate and all. So because it is totally unsupported. The partially supported means it can be a pressure support ventilation or automated tube correction or CPAP. Usually, what is done is, and evidence-wise is also the better one will be a PSV, the pressure supported ventilation, because the pressure support is needed whenever the child is having an ET tube, and the ET tube resistance will be there. So you have to overcome the resistance, and for that you have to give the at least the pressure support required for particular size. Of course, you can so you see that you are maintaining with that PS, you are maintaining the child is maintaining the tidal volume needed. So that is usually the pressure support is PIP minus the PIP. That is the usually the pressure support that you have to give, and here he has to maintain the normal the tidal volume that is required. And in some cases, some persons will they will have a gradual reduction of support, especially in ARDS or children who is chronically ventilated for a long time, or these having a weaning failure 1 or 2 times, or extubation failure for 1 or 2 times, or fail the SBT. And sometimes then you will take a gradual reduction of support. You will go to SIMB pressure support, then to PSV, and then to CPAP. So the pressure supported breathing trial is better because it lessens the work of breathing due to the resistance of the tube. And also you can monitor on the parameters. So you can look at the ventilator and see for the parameters. That is, you can look at the respiratory rate, you can look at the tidal volume, you can look at the minute volume. And of course, you are getting supported breaths. So because of that reason, usually what is preferred is pressure supported breathing trials. And this is the TPS trial, the spontaneously through the endotracheal tube. Usually, the ideal time that was there in the 30 minutes to 2 hours. 30 minutes to 2 hours. You have to put this and see for 30 minutes to 2 hours, and it's not tolerating. He is not tolerating. That means he is not ready to be. So how will you know that he is not tolerating? That is, he will develop tachycardia, he will develop increase in distress, the SpO2 will come down, and he will be cardiovascular dysfunctions. So increase in inotrope support. So all these things. So there, that is means the signs of tolerance. So you have to stop at the first sign of intolerance. So the first sign, tachycardia or increase in anything is happening. So you have to be monitor. You have to be monitoring the child meticulously and continuously, so that whether he is developing the first sign of intolerance. If the first sign of intolerance will stop, and then there is no problem even if you do a next day. So usually you will not do. Suppose he is developing an intolerance, you will not do the procedure further on that day, and next day actually you have to do. You have to do. So the breathing trial, that doesn't mean that the TPS trial, you can go for again the PSV, the pressure support pressure supported breathing trial you can do. So either daily SBT or gradual PSV or IMV weaning. IMV means intermittent mandatory ventilation. Synchronized intermittent mandatory ventilation. So the duration of SBT is 30 minutes to 2 hours. That means it depends on the duration of ventilation and the performance of the previous SBT. Suppose the duration of ventilation is less than 24 hours, like in the first scenario, usually there is no need for a spontaneous breathing trial. So you can directly extubate, or you can just connect these TPs and see whether it's okay. Then you can go for extubation. So 1 to 10 days, you have to see for 30 minutes. Even if you are using PSV, pressure support ventilation, so that has to be continued for 30 minutes. And if he is passing, then you can say that he has passed. So if he is failing in between, he has failed the weaning thrust, and then you have to go back, and next day only you are supposed to do. And more than 10 days of ventilation, sometimes it may require and 30 minutes to 2 hours. So suppose there is a previous SBT failure also, then you have to give it for a longer time. So that is regarding the duration of SBT. The pressure support weaning, usually the pressure support that you give is the PIP minus PEEP. So that you will, so the child is stable, the condition has improved, the child is stable, then you see that minimum settings, and then you see the PIP and PEEP. The difference is the pressure support. And then you can reduce the pressure support to 4 centimeter at least twice a day. That depends on the patient. So the patient, how he improves, how he adjusting with this reduction in uh, pressure support. By that you can decide how frequently you have to do. So 1 or 2 times you can reduce 2 to 4 centimeter or 1 to say 2 centimeter depending on the child's illness, until 5 to 8 is reached. And uh, that is weaning for a pressure support ventilation. And SIME PS, first you have to reduce the rate, and then you have to reduce the pressure support gradually. Then during trial, monitor. So that's what I have already told, that you have to monitor, because you have to detect and stop it at the first sign of intolerance. So otherwise, the child will be in weaning failure for a long time, and it will take sometimes he'll the prolonging the ventilation. So you have to look at the vitals, ventilatory parameters, tidal volume, respiratory rate, respiratory distress, or mental status. So you have to monitor all these things. So what do you mean by difficult to wean? Difficult to wean means simple weaning after first successful SBT. If you are able to wean the child, then it is a simple wean. So difficult to wean means there is a failure in the first test, and then require up to 3 SBT or 7 days to pass an SBT. So then it is called difficult to wean. Prolonged means he is not at all passing the thing. The prolonged weaning. Sometimes he may need a tracheostomy. So simple weaning, difficult to wean, and prolonged weaning. So identify. So if there is a weaning failure, you have to identify the cause for weaning failure and treat. So is it a respiratory cause? That is a common cause, respiratory and ventilatory cause. So the respiratory cause, you have to look at the chest, you have to take an X-ray, you have to look at the ultrasound, any fluid collection, any collapse, or any diaphragm. Diaphragm also, the working of the diaphragm, diaphragmatic paralysis, the contraction of the diaphragm, the thickness of the diaphragm during contraction. All these can be seen by the ultrasound, pleural effusion and collapse, all these things. In the CT, if required, and sometimes the child may be having a critical care neuropathy, and you may have to do a NCV, narrow conduction velocity, bronchoscopies, and massive collapse of the lung, or diaphragmatic palsy. These are the sometimes maybe you have to detect and treat. And sometimes auto PEEP and ET block with secretions, and partially blocked ET. So sometimes that may be the reason for continuing the ventilation. So the ventilatory problems, the respiratory problems, ventilatory problems, we have to find out cardiac problems, any cardiac dysfunction, metabolic problems, psychological causes, ventilator circuit, any leak in the circuit, any secretions. So the nutritional. So you have to, when there is a weaning failure, you have to look for the causes for the weaning failure and treat, and then you go for the subsequent breathing trial, weaning trial. So the extubation, the child is a stable medical condition. Then you assess the readiness for extubation. So the weaning child, he has passed the medical condition is stable, passed the weaning trial test, and then he is ready for extubation. But in addition to that, we have to assess the airway protection. That means, so whether he is a level of consciousness is more than GCS 8, or cough strength. When you give the endotracheal tube stimulate, so you suck out the secretions through the endotracheal tube, till the cough is weak, is the cough is having the good strength cough, and the amount of secretions. Whether you have to frequently suck the endotracheal tube, so need for suction less than once in 2 or 3 hours. Then these things. So he is whether he is able to protect his airway by looking at the level of the consciousness, cough strength, and amount of secretions. Assess the risk of post-extubation stridor. That's also very important. After the extubation, also sometimes he can fail extubation. Sometimes he may be needing a re-intubation. So say there are some risk for post-extubation stridor or post-extubation extubation failure. So that you assess the risk of that. So the risk of post-extubation stridor is associated with increased rate of re-intubation. Suppose you are re-intubating, or prolonged ventilation, prolonged hospital stay. So these are all causes for post-extubation. There are risk factors for post-extubation stridor. Can be due to a vocal cord edema, laryngeal injury, secretions, vocal cord dysfunctions, tracheal stenosis. So there are reasons for. So you have to identify at-risk persons for a post-extubation stridor, and also the first intubation also. Sometimes the first intubation may be having some problem. So you have to mention those problems. Suppose it's a difficult airway, whether any difficulty has encountered during the intubation, what was the difficulty? So then so that also is required. So the risk factors. So usually it's an adult risk factor. So many risk factors: prolonged intubation. So there is a cough, the diameter of the laryngeal diameter, and Apache scoring. So these are all GCS score less than 8, traumatic intubation, history of asthma. So these are the things that is there for an adult. So you should know what are the risk factors for a post-extubation stridor. So the patient at risk, you can look for cuff leak. Cuff leak means there is a normal airflow. So when you deflate the cuff, they deflate the cuff, you will get a cuff leak. So you can auscultate, or you can look at the inspiratory and expiratory tidal volumes and find out so there should be an adequate cuff leak, at least more than 24%. And in an adult, it is more than 110 that is described. So more than 24%, 42, more than 24% cuff leak should be there. If the cuff leak is less than 24%, there will be, we're expecting some edema, and there is a chance for post-extubation stridor. So then delay intubation and treat with glucocorticoids. So extubation. So before extubation, you have to give dexamethasone routinely, but we are not looking at all these things. So routinely, we are using this dexamethasone, 0.5 to 2 milligram per kg per day. Start 24 hours before, and at least 6 hours before you have to start, and continue for 24 hours. And then NPO before 4 hours, empty the stomach. And sedation also, you have to actually sedation protocols, sedation holidays, and very judiciously use the sedation is very important for the weaning and recovery. So the protective airway reflexes and suction of ET tube, oral cavity, nostrils, keep ox. So ready for re-intubation if required. So always keep the necessary things for intubation. Extubation failure. So the re-intubation within 48 hours of extubation is called extubation failure. So causes can be airway secretions with a weak cough, stridor due to edema and inflammation, and bronchospasm. So these are the cause, airway secretions. So that is why increased frequent suctioning. So there is chance for a post-extubation. So the cause, stridor due to edema and inflammation, bronchospasm. So the post-extubation management, usually you'll be giving this nebulization, adrenaline nebulization, and low flow oxygen. So when there is a low risk of re-intubation, a low flow oxygen. So it's a low flow oxygen with a nasal prongs or nasal cannula, nasal prongs, face mask only is needed. High risk of extubation failure, in those patients you have to give HFNC and NIV. So HFNC, especially when you suspect the child will have or child is having hypoxemia, it will correct the hypoxemia, as well as it will give some form of pressure support, and NIV. So in sometimes if there is a frequent weaning failure, spontaneous breathing trial failure, sometimes you are not. So you can wean down to NIV or HFNC depending on the patients. So all these are not so depending on the patient selection and depending on the physician's expertise. So there will be variations. These are all not hard and fast rules that you should be applying, but that you can decide depending on that the experience of the physician and the team of the ICU team is very important in deciding about all these weaning. So what so continue nebulization and other supportive measures. So now we are going through the scenario. Just we are going to the uh, end of the discussion class. So the first scenario. So can anybody? So this is I have already told. No, so the child is no problem with the airway, no problem with the uh, lung parenchyma. He was having some problem with the maintenance of the airway and loss of GCS becoming bad, and there is a difficulty in maintaining there. So then that condition has resolved, and this child definitely just see that whether the child is not having meningitis or sepsis or any other thing, just a febrile seizure, and it is controlled, child is active. So his prerequisites are okay, and then you can without weaning trial also. So if you think that without a weaning, just you can directly estimate, or you just put T tube, or you can have a pressure support. Just go to the pressure support and wean him immediate. So whereas in the second scenario, then with pneumonia and sepsis, so and ARDS, progress to ARDS, that means pneumonia and sepsis associated ARDS and very damaged lung. So the disease is going to cure in taking some weeks. So sometimes you are not expecting. So it's a days, and sometimes days will take and weeks will take for him to wean off from the ventilator. So the depending on the scenario, depending on the indications for mechanical ventilation, depending on the improvement, you have to. So the weaning from ventilation is an art. So that you have to develop on your own. So keeping all these in mind, keeping these basic necessary, this from the evidences, the lesson from the evidences, from the your experiences, you have to make your own way regarding your decision to weaning from the ventilation. So it's an art. So thank you very much.